Good evening. This is Angela Mayer-Guiana Nieto. I'm from Hawaii Pacific University. I'm doing the Advanced Practice Acute Care 3 subject with Dr. Nancy Mitchell, MSN, AGA, CMP, BC. Today is June 22nd, 2025, and I'm going to present my ground rounds with a topic that I found very interesting. That's granulomatosis with polyangiitis. So granulomatosis with polyangiitis is a rare but severe autoimmune vasculitis that damages small to medium blood vessels. It primarily impacts the kidneys, the lungs, but also can cause significant systemic manifestation, which also affects the heart very directly. So, what's the pathophysiology of this disease? This is an autoantibody, PR3-ANCA, that triggers an inflammatory cascade that damages the vessels, leading to granuloma formation with multi-organ involvement. So this is an image to give you guys an idea of how it affects systemically. So if we go from the brain to down, we can find damage in the small vessels of the brain due to the inflammation, the vasculitis. The nose can cause polyps on the nose due to the inflammation. Also, the lungs are affected. You can find asthma-like symptoms, and you can also find infiltrates. And the heart, you can have cardiomyopathy due to the inflammation on the vessels, and because the renal vessels are inflamed and they cause renal failure. You have fluid overload, which causes implications on the heart, and that is also why the heart is very affected. You find also on the abdomen, you can have GI problems due to this inflammation of these vessels. You have petechia in the lower extremities, as well as edema, generalized edema. So it is basically it's a systemic disease, but it's gonna start manifesting, as we said, in the kidneys, and then in the lungs, in the heart, and lastly in the brain. So when we have a patient with this disease, an immediate manage is to support respiratory with oxygen. You can do it via BiPAP. You are going to protect from hypercapnia. Cardiac monitoring continuously the heart. You put the patient in telemetry. We're going to have cautious IV fluids and very strict urine output count. And many of these patients they're in urgent need for dialysis. What are some laboratory findings with this disease? So we have to do a CBC. We detect anemia. A CMP is gonna find, we're gonna detect elevated creatinine. That's that's one of the indications of renal failure, hyperkalemia, hyperglycemia, metabolic acidosis, elevated ESR, the erythrocyte segmentation rate, and you're gonna find PR3 ANCA positive. Arterial blood gas is gonna show normal to to acidosis patient. The chest x-ray, you can find bilateral infiltrates. An echocardiogram, you're going to find an ejection fraction around 30% with dilated cardiomyopathy. So what are some differential diagnoses for respiratory failure, which is a main concern in this disease? The main thing is pneumonia, pulmonary embolism, COPD exacerbation, cardiogenic pulmonary edema, and then you're going to consider arrhythmias due to the bradycardia. So this is one of disease that you need a multidisciplinary care coordination due to a complexity and the systemic component of it. So you're gonna have collaboration between nephrology, cardiology, pulmonology, critical care. We're gonna individualize patient-centered care approaches because every single patient is gonna come with a different scenario with this disease, and timely adjustments based on clinical status. Monitoring and complications or preventions with these patients. I think we already said that they're going to be in continuous telemetry. We're going to take very care of infection surveillance, because these patients, this is an inflammatory disease. Most of the people are going to have steroids, which they're widely known to decrease the immune system because they're anti-inflammatory, anti-immune system cells. So they're going to be very prone to infections. So many of these patients are treated prophylactically with antibiotics. And we want to take a CBC and vital signs every time we see them. Serum creatinine to check the kidney function, and electrolyte monitoring very closely. As frequent respiratory and fluid status assessment too. So why did I choose this disease? This rare inflammatory systemic disease? Because as I was on my rotation on my clinical rotation at the ER, there was this 58-year-old male that came into the ER, and he came brought by the EMS with respiratory failure, intubated, and it was a patient that took us a long time at the ER. Like usually the patients at the ER we see them for about 30 minutes, and that's a lot of time. Like probably you go, you check them, order some labs, and then the labs come back, and then you recheck the patient, or there's some other things if there's another thing missing, and that's it. It's a lot of back and forward. But this patient, there was an interdisciplinary team just with this patient. There's a lot of things going on, and we spent a lot of time with this patient. And I think that from all this experience, I got a lot of things to learn, and I got a lot of things that I would like to improve as a healthcare worker, that this patient kind of gave me the insights for that, which I feel that it was a very nice thing. So this was a 58-year-old male, a young male, with a history of granulomatosis with polyangiitis. Just for the a little cultural thing, this granulomatosis with polyangiitis was a Wegener disease, but the Wegener was a Nazi, was part of the Nazis. So the American College of Rheumatology decided to get rid of the last name, and they just so many of us knew this disease by Wegener's disease, but now it's granulomatosis with polyangiitis. So this patient presented with an end-stage renal disease, a non-ischemic dilated cardiomyopathy as a history, acute respiratory syndrome. He had already encounters with respiratory issues, and he has a history of sinus pain, cough, bleeding with cough, shortness of breath, frequent episodes of shortness of breath. So the patient presented to us with tachycardia, acute hypercapnic respiratory failure. It was hyperkalemic, acidotic, and so as a social thing, the patient happened to have missed the dialysis because it was that day he had the dialysis, but the spouse mentioned that he missed, so that was Tuesday, he missed the Saturday too, so he was a patient that was non-compliant with his dialysis. And she also mentioned that she ate plenty of peanut brittle, so peanut brittle would not cause any damage on a regular patient, but this patient happened to have renal disease, so that does affect the patient with a renal disease. So this patient was on, as I mentioned, on respiratory arrest, brought and intubated by EMS. That patient weighed 139 kilos. Well, his BMI was 42.2, which means he was category 3 for obesity in the classification, class 3 obesity, which is severe morbid obesity. His blood pressure was 124/105. The diastolic is a little bit high. The systolic is fine, but nothing concerning. The diastolic is concerning, but the systolic is not. Neurologically unconscious, the patient was non-responsive when he arrived to the hospital, which made the nursing part a little bit more difficult because we could not retrieve any information from him. He did not seem like the palpation was soft, was tender. You could hear bowel movements. He actually, I think when he was coming from the ER, he had a bowel movement when he was coming from the EMS. So his abdomen was non-tender. There was no guarding signs or anything. So at the arrival was complicated by hyperkalemia. The patient was very hyperkalemic, so that led him to cardiac arrest. So we had to start CPR, and we achieved resuscitation methods were successful. The EKG presented with peak T waves and widened QRS, which suggests hyperkalemia. Pharmacological intervention for Wegener's disease, usually we do prednisone, which we gave at the ER. For the granulomatosis, for immunosuppression. Cyclophosphamide is not longer indicated, as I read on one of the articles. They don't longer give it as first line. Furosemide needed for fluid overload. The atropine was given every 3 to 5 minutes, is the indication 0.5 milligrams. Tylenol is given for fever and possible pain control. Amiodarone for the antiarrhythmics. buspirone for anxiety, heparin for anticoagulation, phenylephrine. The patient was said to be on phenylephrine on 160 micrograms per minute, continuous infusion. Propofol was given 10 micrograms per minute, and it's titrated by 5 micrograms per kilo per minute, and maximum in 5 minutes. Dextrose was given. The patient was hyperglycemic at arrival. His glucose was 135. Vancomycin for infection coverage due to the prednisone in the first place, and also because we had to put a central line, an arterial central line in the femoral artery, but the patient, as it was an emergency line, the procedure was not sterile, so the vancomycin will cover for possible inflammation. So the patient took Lokelma oral, that is for hyperkalemia. So the patient had a history of hyperkalemia before arriving to the ER. At the ER, we saw the hyperkalemic state exacerbated. Sodium bicarbonate was given, an IV bolus for acidosis, in epinephrine 1 milligram IV bolus times 4 was given also during the ACL as a resuscitation methods. So some of the patient specific biological factors that we found in this patient, the obesity, the patient's weight may contribute to tachycardia, potentially complicate the management of the cardiovascular health, because the heart is obviously overwhelmed trying to pump all the blood to all the parts of the body, and if the body is way too big, then the heart has to do extra efforts, so the heart is always compromised. This condition can lead also to other health issues such as diabetes and hypertension, which may not yet be diagnosed. The patient did not have a history of diabetes, but he had high glucose. So probably one of these learning experiences with these patients is the amount of things and education and assessments that we can do in this patient. Unfortunately, in my shift, as I said, the patient was neurologically non-responsive, but if I was his provider, or if I could establish care with that patient, it would be a very good opportunity for me to assess all the situations with this patient. So it could be interesting to set a plan of care with the patient based on the patient's preferences, on the patient's health goals, and it would be a great opportunity as a nurse practitioner for me to have this type of patients to kind of integrate all the knowledge and the nursing parts that are the things that I am more passionate about. I love the medical part, I love the disease, I love the physiopathology, but honestly the thing that for me gets me the most is the opportunity to get into the patient's health goals and establish them, and can come with a plan together. Tachycardia, these symptoms require careful monitoring and management, which may involve adjustments to medications and life changes. Another slide for biological factors is the kidney health. The patient is not compliant with dialysis appointments, suggesting possible deterioration in the renal function that could worsen his overall health and status and lead to additional complications. We know that this patient, we know now that this patient is an end-stage renal disease patient. Dietary non-compliance. This patient struggles with adhering to recommended dietary plan, which can exacerbate his obesity and the tachycardia. The poor dietary choices, such as this high sodium intake, unhealthy fats, and inadequate intake of fruits and vegetables, can further complicate the cardiovascular health and his overall well-being. Psychological factors for this patient specifically, the non-compliance is a big thing. This patient's non-compliance with treatments and dialysis appointments indicates potential psychological barriers. Possible, I don't know, I'm just thinking out loud, possible denial of the disease, possible a little bit of depression, a little bit of anxiety, probably to go to the doctor to get those, I don't know, the dialysis port or something. So it would be a wonderful, wonderful thing to keep looking for this patient. If I could possibly do a follow-up with him, it would be wonderful for me. Willingness to change. He's unable to. So I was unable to assess directly the willingness to change, to improve his dietary. But the wife was there, and the wife is an ICU, a former ICU nurse, and she said that she was just saying he does not care. Apparently the patient has this habit of eating this peanut, and he knows by her, what she told us is that he knows that is not very healthy, that he has to suspend it from his diet, and she said, like, he just does not care. He just does not care. So that's a big thing, the willingness to change. Adjustment issues. So this patient has a history also of coming from Texas to live to Connecticut, which is a very big change. This could lead to feelings of isolation, lack of support, especially if the patient has no family or support people here, just his wife. Probably he hasn't established care with any doctor, or probably hasn't bonded yet with a group of doctors here in Connecticut. Social factors with the patient. We could assess. I could not really assess whether if he lives on a comfortable house, if he has all the services, or if he has support. But definitely the patient has a partner, a wife that's a former ICU nurse, as I mentioned before, with that can provide solid foundation for support. However, that also may bring challenges if he is resilient to receive care or having conversations about his health. Socioeconomic status. The recent job change for his wife may affect the financial stability. Possible change of insurance company. Probably he doesn't know his benefits yet very well. So that would be a great learning opportunity for us as nurse practitioner to establish care also with social work, and assess whether if the patient has barriers to, like, economical barriers, or probably a psychological barriers, or what is it that the patient needs. So that would be great if we could go a little bit deeper on these aspects, because I think besides the complexion of the disease, the way that the patient can improve his health by being compliant with his appointments, compliant with his diet, compliant with his medicines, it would be a huge help for him. Access to healthcare, depending on their new location, they might face a challenge finding healthcare team, as we said already, in Connecticut, impacting his treatment community. Family dynamics, the dynamic with his wife, an experienced healthcare provider may influence his perception of his illness and treatment options. There could be tensions if he feels frustrated by his lack of compliance, or if she assumes the caretaker role instead of actively engaging him in his care journey. So, summary of the biopsychosocial patient-specific factors. So, this patient biopsychosocial assessment highlights the importance of addressing not only the biological aspects of his health, which is the disease itself, but also the psychological and the social factors that influence his treatment, compliance, and health outcomes. A multi-phased approach that includes psychological support, education, enhanced communication with healthcare providers, and strategies for foster and cooperative environment with his spouse may be essential for improving his overall health status. Plan-specific components of health promotion and primary prevention. For this patient, I cannot address more the importance of getting vaccinated. I don't think he wants any other comorbidities than the ones that he has. I don't think he wants any more complications than the ones that he has right now. So being vaccinated update, it's going to be a very important thing for this patient. We can educate the patient in the importance of adhering to their treatments and attending to their regular follow-up appointments once we can assess what is the cause of his non-compliance with this. Encourage lifestyle modifications to manage related symptoms and complications. We should consider depression. We can consider insomnia. Probably he's uncomfortable at nights. He cannot sleep very well. He feels overwhelmed by all these things that's happening to him. His renal disease and an adequate diet. All those things are a lot of learning opportunities for us to give to the patient and empower the patient. What's the healthcare impact on the plan of care? Well, the ability and access is one big thing that we require multiple approaches. We need the nephrologist, the pulmonologist, the immunologist. So all these things, all this the specialties and different doctors that the patient needs to see, it's going to impact on the plan of care. Cost and financial impact. Chronic treatments and dialysis can be costly despite support. What delivery methods could we find for this patient? We have the private and the public hospitals, and it affects the time that he can access for care, possible the equipment that the hospitals have, the level of care that the hospitals can offer to this patient. All those things are very important. So resource availability, we can get social support by the social workers. We can assess the transportation, if the patient has transportation to get to his appointments, to get to his dialysis, if he can drive or he depends on someone. The patient education and the ways that the patient likes to be educated, if he prefers the visual learning, if he is a listener, if he is a visual, if he's a video learner, we have to assess all those things so we can can do a plan of care for the patient. Regulations and clinical guidelines are going to shape our care and quality of the patient outcome. The more we have information and guidelines, the better we can serve these patients, because we can follow this already established guidelines, and we just complement with all our things that we have to add to this patient. Education and social support. So we need to give the patient literacy. We need to teach the patients about their disease and find them resources so they can learn more about the disease. That is going to it's going to empower the patient in for the long term and for their disease control. They're going to learn about their disease and can take action. And great. Implications for GPA, ESRD, or dilated cardiomyopathy patient is access to multiple the nephrology, pulmonology, cardiology, social work support for transportation, insurance, navigation, patients' education, importance of site choice based on the patient needs, the financial availability, the constraints, and the clinical complexity of this patient. What are some follow-up strategies for this patient? Well, when it comes to follow-up and evaluation strategies, it is essential to have a structured approach to ensure effectiveness and clarity. So it's going to be timely communications, always follow up with the patient, set a timeline. We see you in 1 month, we see you in 3 months. Set a timeline to see when are we taking the next labs, when are we taking the next tests after the initial interaction. Talk about what we want to get improved, where we want to go to, set goals with the patient. We're going to create milestones and really, how can I say, very realistic milestones, so with that way the patient's gonna keep engaged, because he's gonna see improvement or that he reached the milestone, which is something very encouraging. Personalized follow-ups. We're gonna tailor our follow-up. We're gonna message the patient with specific things to get interaction, especially with a non-compliant patient, that we know that if we don't do follow-up calls, if we don't do follow-up questions, that patient might not be interested in their health. If we kind of demonstrate that patient and reflect the interest that we have on his health, that is probably going to be something that the patient gets attentive, and then we can foster strong connection with the patient, and then the patient could get stronger with his health. So use multiple channels. They suggest to not limit ourselves to just an email, or we can consider phone calls, social media, face-to-face encounters, check-ins. We can use home health. Go check to his home, go check to the patient, maintain a good, a healthy relationship with this patient. Set reminders. We can create a calendar with the patient. We can have access to calendars and do a visual check-in. We want to get this time here, we're going to get to this objective, we're going to do this milestone, and create a calendar. Probably ask the patient to bring the calendar next time, so we can check the dates, check the appointments, check how we're doing, when is our next follow-up, when is our next dialysis, what are we looking for, what, so also like what are we looking for to feel like the patient's symptomatology, if he's got low sugar, high sugar, or whatever. So those things can also set us like a way to communicate with the patient and set up good and timing limits. Feedback requests. In your follow-ups, ask for feedback regarding their experience with the service provided. This is going to show that you value their opinion and that you're committed to improvement too. Provide additional information if relevant. Share additional resources, updates, insights that may be beneficial to them following up with an initial conversation. Evaluation strategies, how to evaluate our patients. We define clear objectives, and we start by outlining what we want to evaluate, and then we're going to establish clear metrics for success that align to your goals. Like creatinine levels. What is going to be our goal for creatinine next time we see each other? That's going to tell us if you're complying with your dialysis, if you're complying with your medicines, if you're complying with your diet. Our weight, how many pounds are we going to lose, or how are we going to measure the weight, how are we going to measure, that's going to reflect our intake, that's going to reflect how much have we improved with our diet. And so it has to be preferably has to be measurements and established metrics. Surveys and questionnaires. We can use surveys to collect feedback from our clients or stakeholders. Ensure the questions are clear, concise, and so we can gather accountable insights. Performance metrics. We're going to track quantitative data related to performance, including progress against deadlines, budget adherence, and the quality of the outcomes. Evaluation strategies, continuation, regular review meetings, schedule periodic check-in times. We already said that before on a slide before. Discuss challenges and adjust strategies as necessary. Peer reviews, we're going to gather insights from our colleagues or external parties to gain diverse perspective on performance and outcomes. Sometimes if you don't have an idea, some other person can have an idea on how to get the best for our patients. Reflective practices, we're going to encourage a culture of reflection and asking the team members to share what we work. So we ask the patient to reflect on what we're doing, to make the goal, the health goal, a little bit more concise and more understandable for the patient. We're going to document the outcomes, keep thorough records of the evaluations to track the progress over time, and inform future strategies. We're going to adjust and adapt. We're going to be flexible with our approach, and if the patient did not get to the goal, if they did not go to the whatever pounds he should lose, we're going to review the strategies, see what was going on, and we're going to try to ensure that we improve continuously, but not like punishment or anything like that. So implementing these follow-up and evaluation strategies, we are going to foster stronger relationships. We're going to enhance performance and achieve better results with our patients with our projects and initiatives. Okay. I kind of went missed some of the um, the slides, but so in summary and key terms, granulomatosis with polyangiitis causes a multi-organ disease with complex management needs, as we could see that. Immunosuppression, fluid optimization, and cardiac support are key especially for this patient. Differential diagnosis ensures that the targeted therapy, it ensures that we're doing the correct therapy. And then the team approach on patient-centered care, it's going to optimize our outcomes. So one of the most important things that I took from this encounter with this patient is the incredible opportunity that we as nurse practitioners have to be the ones that treat the patients, assess the patients, and mostly that we can really make difference with the patient's treatments and compliances, because we are the ones that have a close communication with them, and we can have a very good relationship with our patients, and they can have the best healthy life possible if we are dedicated and interested in them and interested in doing it. I'm really gonna follow up with this patient because I want to know what is he up to, what was his results, and why is he not being compliant, and how can I help this patient to have a healthy life and the best of his health from now on. He's a young person, he's got a lot more to live. So thank you very much for listening, and I know this was a very long and very tedious topic, but it is very interesting, and this multidisciplinary diseases have a lot to give us as healthcare providers, and we can do a lot with these things, and I find them fascinating. Thank you. Have a good night.